Hi everybody, you are welcome again to the second part of the lecture, which will be about uterine fibroid. What we will discuss in it, the definition and risk factors for fibroid, what are the types of fibroid, how we will diagnose it, and we will discuss the history, the symptom of the patient, examination, and the investigation. Then, what are the lines of treatment of patient with uterine fibroid, and lastly, the complications that may happen. So, first, what is uterine fibroid? It is a benign tumor of uterine smooth muscle termed as leiomyoma. They are highly prevalent, being found in approximately 40% of women overall. The risk factors for development of fibroid is nulliparity, obesity, family history, African racial origin, and hyperestrogenic state. The factors that may reduce the incidence of development of fibroid is multiparity and smoking. But ensure we will not advise the patient to be a smoker, so to decrease the risk of fibroid. But they found in researchers that smoker patients or women, the incidence of development of fibroid are less than those who are not smoking. What are the classification or types of fibroid? We have mainly three types of fibroid depending on their position regarding the uterus. We have submucous fibroid, this is an example of submucous fibroid. This is a submucous fibroid. The difference between them is that this is intracapillary and with pedicle. This is lined with the endometrium, but also it is submucous. The second type, which is the intramural fibroid, which is found within the myometrium of the uterus. And the third one, it is the subserous fibroid. This is pedunculated subserous that may be large enough to occupy the whole abdomen or sometimes very small. This is also a subserous fibroid. We also have fibroids that may be related to the broad ligament, which is intraligamentous fibroid, or to the cervix, which is cervical fibroid or parasitic fibroid. We can see the fibroid in the vagina, sometimes even far away from the pelvis, in the lungs. This surely will be confirmed by the histopathological examination. So these are the types of fibroid: submucous, intramural, and subserous. This is a real picture for women intra-op, and as you see, the uterus is not seen, but what we see is these multiple uterine fibroids. The fibroid may be present single one in the uterus, or maybe multiple of different sizes and different shapes. This is uterus which is full of fibroid. There is distortion in the anatomy of the uterus at all. This is another picture of fibroid, which is gross appearance of the fibroid. This is after hysterectomy. As you see, this is the cervix, and this is the uterus, the tubes and the ovary, and these are the multiple uterine fibroids that are present. This is another example of uterine fibroids. There is a cut section in the uterine wall, and as we see, this is the fibroid, which is submucosal fibroid. It occupies the whole cavity of the uterus. This is another picture of fibroid. It seems to be submucous fibroid. This is the uterine cavity, or it may be intramural. We cannot be sure because this is diagnosed intra-op. It is uterus after hysterectomy also. See this picture and put it in your mind when we describe the gross appearance of the fibroid. The fibroid is lighter in color than the normal myometrium. The cut surface of the fibroid will be glistening, pure white with a smooth muscle arranged in trabeculated or wall configuration. It is firm. It is a solid tumor, well demarcated and surrounded by pseudocapsule. As you see, it is well demarcated, and by this we differentiate it from adenomyosis, in which it invades the whole myometrium. There is no line of demarcation between the adenomyosis and the myometrium, while in fibroid there is a line of demarcation because it is surrounded by a pseudocapsule. The other feature of it is it is relatively avascular. So it is lighter in color, it is solid, there is a well demarcated pseudocapsule, and it is relatively avascular. The symptoms of patients or women who have uterine fibroids will depend on the number of the uterine fibroids, the size of it, and the site of it regarding the uterus, whether it is submucous, intramural, or subserous. So many patients will be asymptomatic, and she discovered that she had fibroid when she do an ultrasound, or ultrasound was done for her, or in case of operation, for example, for ovarian cyst, and they saw that she have uterine fibroid. So it may be completely asymptomatic. Other patients will have symptoms. The symptoms, as we it depends on the position, the number, and size. Most patients who have submucous fibroid will have an abnormal uterine bleeding because it affects the endometrium. Usually those patients will have heavy menstrual bleeding, but sometimes they may have intermenstrual bleeding, others may have postcoital bleeding if she has cervical fibroid, and etc. Patients with intramural fibroid, if the fibroid affect the endometrium, also they may have abnormal uterine bleeding, but unlikely patient with subserous fibroid will have an abnormal uterine bleeding. The other symptoms that may occur in those patients is pain. They may have dysmenorrhea, dyspareunia, or chronic pelvic pain. Subfertility may occur in patients with fibroid, either because it may affect the site of implantation, or it may close the ostium of the tubes, or sometimes it press on the tubes and make them blocked. This its effect on the fertility. Patients may become pregnant, but she may have recurrent pregnancy loss. The other important symptoms that may occur in those patients is the bulk effect on the adjacent structure, and this happens mostly in patients with subserous fibroid. If it is large enough, that may press on the bladder, on the sigmoid colon. For example, on the bladder, the patient will have frequency of urination and urgency. Sometimes it press on the blood vessels and the inferior vena cava. The patient will have varicosity in the lower limb, and etc. If the fibroid is large enough, for example, multiple, or the patient neglect herself, she may have an abdominal distension. And sometimes the patient presented just like a woman who's pregnant and she's in term pregnancy because she neglects herself. So these patients may have also GI symptoms, vomiting, nausea, constipation, or it may press on the ureter and the kidneys, and patient may have ureteric obstruction and hydronephrosis and other symptoms related to the urinary system. If the patient gets pregnant while she has fibroid, there may be complications that occur during pregnancy. So what is the effect of fibroid on the pregnancy? Is, first of all, as we said, she may have pregnancy loss, miscarriage, or she may have placenta previa because it's, for example, if it is fundal fibroid, submucosal fundal fibroid, it will affect the site of the placenta. Abnormal lie, there may be increment in the incidence of cesarean section in those patients, and when the patient delivered, she may have postpartum hemorrhage. What are the findings in those patients? First of all, by general examination, we should check for signs of anemia, and if the patient presented with acute bleeding, we should check her vital signs. On abdominal examination, there may be visible and or palpable abdominal mass. On bimanual examination, there is enlarged, firm, smooth, or irregular, non-tender uterus. So we should differentiate it from adenomyosis, if you remember in the previous lecture. What is the natural history of fibroid? What I mean that, what is the fate of fibroid? The fibroids are benign estrogen-dependent tumors that can enlarge during pregnancy in response to the hyperestrogenic state, become common with advancing reproductive age, and shrink after menopause. They can undergo degenerative changes, usually in response to outgrowing their blood supply. What are the forms of degeneration? First, there is the red degeneration, in which there will be hemorrhage and necrosis occurs within the fibroid, typically presented in the mid-second trimester pregnancy. And this patient will be presented with acute pain. Red degeneration occurs during pregnancy. The patient will be presented with pain, sometimes fever, and we will manage the patient symptomatically. We will not interfere with her by surgery, analgesia, fluid, antibiotics, and follow-up until she became well. The second one is hyaline degeneration, cystic degeneration. Also, rarely there is malignant or sarcomatous degeneration. The fibroid in very low percentage, there is risk of development to CA, leiomyosarcoma. We should put this in our mind when we found it for the first time in postmenopausal women, because the patients usually who have uterine fibroid are presented in their 20s to 30s, not presented for the first time when she's 50 or 60. So we should put in our mind that it may be leiomyosarcoma. And if it is a rapidly increasing size, also we should put in our mind the risk of malignancy in those patients. While in most of cases it is benign. How we will diagnose it by investigation? We have first transvaginal ultrasound or transabdominal ultrasound, and this depends on the size and the number of fibroids. For example, if the patient have if she has a large fibroid and the uterus is very big, for example a 20-week size or 28-week size, so it cannot be recognized well by transvaginal ultrasound, so we should do transabdominal ultrasound. Saline infusion sonography will help us if the patient have submucous fibroid. Hysteroscope also it aids us in diagnosis and removal of submucous fibroid. MRI is a useful method for the diagnosis, for the localization of fibroid, and especially to follow the patient when we want to do for them uterine artery embolization. So we do for her MRI, and then after the embolization, we follow her response to the treatment by MRI after doing the embolization. What are the lines of treatment? The lines of the treatment will depend on many things, and important one is the presentation of the patient, what are the symptoms, and also about her parity, if she complete her family or not. So the first line is conservative, in which we just follow the patient. In this case, the patient should be asymptomatic. Those patients who are detect the fibroids incidentally by ultrasound or during surgery. It may be useful to establish the growth rate of the fibroids by repeat clinical examination or ultrasound after a 6 to 12 month interval. The other line of treatment is the medical treatment. The main indication for medical treatment is heavy menstrual bleeding, and the main treatment used is mirena, the levonorgestrel intrauterine system. And those patients who use for it, we should ensure that there is no contraindication for the mirena, and we should tell the patient that it is a form of contraception. Also, we can use for them, for treatment of menstrual bleeding, we can add tranexamic acid or mefenamic acid, and sometimes combined pills. Another form of treatment that will help to alleviate the symptoms, to decrease the heavy menstrual bleeding, to also decrease the size of the fibroid, is GnRH agonist, gozerline, bozerline, whatever, those treatments. The other new treatment, which is used in the management of heavy menstrual bleeding because of fibroid, is selective progesterone receptor modulator, which is one of its example is ulipristal acetate, and there is another form which is the ismia. They are oral tablets. These are oral tablets, and the good thing is in this type of treatment that it will not cause a menopausal sign and symptoms in the women who use it. On the contrary, GnRH agonist will cause these symptoms to the patient, so it will affect the duration of its use. Let's talk shortly about GnRH agonist. Advantage of it is improvement of the heavy menstrual bleeding, and also it may produce amenorrhea, improvement of anemia and relief of pressure symptoms. It's reduction in the size of fibroid, especially when you use it for at least 6 months. There is 50% reduction in the size of fibroid, reduction in the vascularity of the tumor. So this will help in the decrease the bleeding during surgery, either by myomectomy or hysterectomy, and it may facilitate laparoscopic or hysteroscopic surgery because it will cause a shrinkage to the size of fibroid and also to the size of the uterus. The disadvantage of its use is that it will cause a hypoestrogenic state, so the patient will have the menopausal side effect, vasomotor symptoms, osteoporosis. It's costly. The other disadvantage, as any medical treatment, that when we counsel the patient about the medical treatment, we should tell her that when we stop the treatment, there will be regrowth of the myoma. Degenerations in the myoma, which may cause difficulty in myoma inoculation. The usage of GnRH agonist may affect the line of demarcation between the fibroid and the normal myometrium. So the use of it may cause the surgery to be more difficult. So neither GnRH nor the SPRM, the selective progesterone receptor modulator, represent a viable long-term treatment. And when we stop these treatments, the ovarian function will return and fibroids regrow to their previous dimensions, which is an important thing. The other line of treatment is the surgical treatment. The factors that affecting the type of surgical approach depends on the age of the patient, the parity, and her future reproductive plans. We have minimally invasive hysteroscopic surgery can be used to cut away a submucous fibroid. Where a bulky fibroid uterus causes pressure symptoms or where heavy menstrual bleeding is refractory to medical interventions, the options will be myomectomy. We should remove the fibroid. And if the patient complete her family, we can do for her hysterectomy. In myomectomy, we can preserve the uterus, but in hysterectomy, it is a definitive treatment. We will remove the uterus and the whole fibroids at present. Uterine artery embolization is a technique performed by interventional radiologists. It involves embolization of both uterine arteries under radiological guidance. The complications include fever, infection, fibroid expulsion, and potential ovarian failure, which is rare but may occur, and abdominal pain. It's widely used nowadays. The complications of fibroid, as we say previously, there may be degenerations, necrosis of the fibroid, infection of the fibroid, rarely sarcomatous changes, hemorrhage inside the fibroid, and polycythemia because of the pressure effect of the fibroid on the kidney, and it will affect the erythropoietin hormone secretion, and this patient may have polycythemia. And thank you.